Hello, everyone. My name is Corey Thornton. I'm the senior editor here at Open Minds, and welcome to today's Circle Executive Roundtable, How to Develop a New Strategy for Whole Person Care, a Guide to Designing Your Integration Roadmap, featuring Open Minds Senior Associates Christy Dye and Karen Carloni. Ms. Carloni is filling in today for Deanne Cornette, who could not make it. Before we get started, I have a few housekeeping reminders. Your audio will be muted for today's briefing. However, if you have any questions, we encourage you to submit them using the question box located on the right side of your screen. If time permits, we will answer those after the presentation. And finally, the slides and recording for today's roundtable will be archived and available for elite members on the Open Minds website starting tomorrow. And with that, here's Christy.
Good afternoon, everyone. Corey, tell me if I'm on screen with the deck.
Hit from beginning again.
Okay, give me a second. All right, there we go. So, good afternoon, everyone, or good morning, depending on which part of the country you're in. My name is Christy Dye. I am a senior associate with Open Minds. I am joined today by Karen Carloni, also a senior associate in Open Minds. And we're actually pretty excited to spend a little time with you today to talk about how you really get started with a whole person care strategy and an integration roadmap. Both Karen and I have a number of years of experience in setting up and overseeing integrated care settings, and we're hoping that we might be able to share some lessons that we learned along the way that you can use to sort of forward your own strategy. So our agenda, we'll talk a little bit briefly about the evidence for whole person care, and then really dive into how you get started. So looking at analysis of markets, models, and financial feasibility components. And then I'll turn it over to Karen, who will spend a little time talking about what are some of those core practice themes and components that are common across whole person care settings and really set it apart from traditional or care as usual. And then we'll talk a little bit about the Open Minds whole person care readiness assessment and how organizations might use that to help forward their own strategy. And then time permitting, as Corey said, we'll have a few minutes for discussion and questions. So these are just our learning objectives for today. And I would just like to dive in. So we're going to talk a little bit first about just some of the evidence for whole person care, because I always think it's important to start with some concepts and definitions. And two that are prevalent in this area is really talking about whole person health care, which is an approach to care delivery. So one of the things that differentiates whole person care as an approach from care as usual is it's really recognizing that health is a product of multiple factors. So where people live, we've all heard zip code is more important than genetic code. So physical health, mental health, environmental exposures, all those things have impacts on health and are components of what whole person healthcare addresses. So organizations that adopt a whole person care approach are going to be spending, prioritizing screening for various physical and mental conditions, as well as those social risks. This is social determinants of health. And then in contrast, we have integrated care, which is really the structure and the delivery model. It does make effective whole person care more possible when you're using an integrated approach. And integration really deals with access to multiple disciplines and then information sharing amongst those disciplines. So it's characterized by high degree of collaboration across different professionals and organizations treating a person. And part of that, to make that collaboration and information sharing possible, is you're going to be investing in technologies, different types of staff roles, and payment models that make collaboration happen more easily. So those are sort of some of the distinctions that we make when we talk about whole person and integrated care. So just briefly, the markets that we find ourselves in these days, have changed considerably over the last 3 or 4 years. I think from the first point at the top with markets driving new healthcare delivery models, I think something that we're all starting to recognize is the way we did business always is not necessarily the way to be successful in the future. and just breaking even seems to be sort of the new normal. So financial sustainability really is no longer certain in the ways that we've always delivered healthcare. There's also just in general this focus on models involving whole person healthcare solutions. It's one of the reasons that you're here today. Payers really are showing a preference for treating people in an integrated and whole person fashion. And then everyone from the Center for Medicaid and Medicare down are creating flexibilities in the ability of providers and health systems and payers to actually use Medicaid and other dollars to treat social conditions. So we're seeing a lot around states setting up housing programs in the Medicaid program using Medicaid dollars, and that's a very new thing from how those systems have operated in the past. And then finally, health plans themselves are prioritizing paying for the outcomes of whole person care delivery. And in some cases, health plans themselves are becoming providers and being part of that market force that's competing with traditional healthcare settings. On the other hand, there really is now beginning to be a body of evidence that whole person care actually is very effective. So this first study at the top on behavioral health homes, that comes from Psychiatric Services, and it was a study of 11 community mental health centers that had full-time registered nurses on staff to do assessments, do that follow-up care coordination, do some of the preliminary procedures. And it really did find that health homes are able to produce reductions in hospitalization, as well as increasing just routine PCP services, so that people are seeing a PCP on a regular basis instead of going to an emergency room, as well as reductions in spending. And then on the primary care side, one of the seminal studies reviewed 125 different models of primary integrated care, and also found substantial evidence of improvements in how people experience that care, their clinical outcomes, as well as reduced costs. And then finally, this actually comes from McKinsey and Company, which is a major national think tank. And one of the things that they found in looking at whole person care is even considering an initial $60 billion investment in behavioral health outpatient services solely to bring behavioral health back up to parity with primary care, because for so many years there was no investment really in behavioral health. Even with that initial investment, whole person care stands to produce a 3-to-1 return, so a net $185 billion and you'll see it, how they calculate it by setting, if we nationwide adopted a whole person care model. So where does that really leave organizations as they're thinking about next steps in terms of whole person care approaches? Well, organizations that adopt a whole person care and an integrated delivery model really experience these kinds of benefits. So we're leveling the silos that have traditionally existed between physical care, intellectual developmental disability services, behavioral health addictions, and that improves patient access to all those types of disciplines, ideally in one service setting. People who are adopting, or organizations that adopt whole person care, are really paying attention to those social drivers. So again, universal screening, referral, care coordination with community-based organizations to address social needs, and then managing complex consumers. When you do steps 1, 2, and 3, you're going to find yourself as a whole person care provider sharing data and using data and information systems in order to communicate, because that's naturally what occurs as you start to manage complex populations and adopt that whole person cross-discipline approach. By investing in technology and data systems that help you manage and produce the outcomes of whole person care, you're also on the side going to maximize value-based payments, because they all flow together. So our summation, of course, is always that every organization needs an integrated care strategy. These are just some of the prevalent data points around what we're seeing in the markets today: 500 CCBHCs, 456 Medicare ACOs, 10,000 primary care practices that are certified as patient-centered medical homes. So it's very prevalent in the field today. So let's move on to how then, for you as an organization, do you actually get started in whole person care. So we're going to talk a little bit about some of the factors that you'll want to be thinking about and actually doing some assessment around in order to select a whole person care model that is a best fit for your organization. So we're going to talk about market, we'll talk about a little bit about models, and then very important, we'll talk about doing the necessary testing to make sure the model you select for the population you want to serve actually can produce some revenues for you. And so what does that financial feasibility analysis look like? And then I also just wanted to say, it really is true that whole person care is both a journey and a destination. I'm sure, Karen will share a little bit of her story in a moment. I can tell you from me, setting up a network of 7 integrated clinics out here in Phoenix, Arizona. It took me 5 years and movement through at least 3 different models of how we were going to deliver whole person care over a 5-year period of time before we finally landed on the model that worked best for our organization. So it is a journey as well as a destination. This is just sort of a quick view of step 1 of the integration readiness assessment process, and these are the pieces that I'm going to be talking about next. So we start really with market. So who is the population that would be ideal for your organization to serve? So of the people who are in your current client base, who would benefit most from an integrated care service? What do they need? What are the clinical services that they need, or the screening for social determinants of health, so that you can come up with a clinical scope of service for your whole person care program? And then taking a look at what are the opportunities that are out there in the market. So, we talked earlier about complex consumers. Those are the individuals, the 10% in the United States that utilize 70% of healthcare services. So do you have those types of individuals? And I'm betting you do. Who are they? What do they need? What's their clinical profile? As well as really looking at in your organization who is missing, who is underserved, where are the gaps? So to do any of the customer market analysis, you really need data. You're going to need data about your patient population. What are their health needs? Who will pay for the service? So who are they enrolled with for coverage? Are they seeing other health organizations in the community that you might establish a collaboration with? So if you're sharing a large number of patients with a couple medical groups, those might be good places to start in terms of a collaboration protocol or something in a coordination model. And then again, you'll need utilization data, particularly for emergency department visits, inpatient utilization, in order to really get a handle on who your complex population is. And this is something that you've probably, many of you have seen in the past. We call it the low-low, the high-high, low-low model, the 4-quadrant model. This one has been updated and refreshed by inclusion of likely payer source, depending on whether individuals, which of the 4 quadrants the individuals fit into, as well as what's that level of social determinant risk, their social drivers of health, what's the level of that that occurs in associated with that high-high, low-low box. And this is important because you'll really want some type of visualization of your patient population so that you know who your anticipated customers will be and what will they need clinically, what level, what volume and type of social risks you'll need to deal with in your whole person care practice, and who really will be the primary payers for that service. So I find this to be a very helpful visualization model. Then we move into really market intelligence. So as part of this, you'll be looking at what the competitors in your area are doing. Are they building, large integrated practices, or are they just implementing, social determinants of health screening? You want to remember that some competition is virtual, so that may not be physically located in your region, but you do want to know how are you going to stand out? What's your market niche vis-a-vis competitors that deliver similar services in your region? And then, very important, what do your payers want? What are they wanting to buy? We know that they want to purchase whole person care services, but do they have a particular approach or model, integration model, that they're more interested in than others? So competitor and payer market intel, very important for moving your program forward. And then finally, we talk about models. So there's various types. I'm going to show you a full list in a moment. I would say coordination and referral is still in at least the behavioral health arena, probably the single most common model that we see. Rapidly, certified community behavioral health clinics are catching up to coordination models. We'll talk about that a little bit more in a moment. But associated with model type is you need to know how you're going to staff the program. So you've defined a clinical scope of service, a clinical and whole person scope of service. So you know what services you want to deliver because you went through market and market intel and all that. So what are the exact physical and behavioral healthcare services that you need to bring on board or link up with in order to support that scope of service? And that's going to be different depending on what type of provider you are. So if you're a behavioral health provider, if you're a primary care provider, if you're an IDD provider, different types of partnerships. Can you do it through a partnership? Will you have to add staff? If you're going to add staff, will you contract for them or will you employ them? And then always considering, is there a virtual or hybrid flavor that you can bring into that model to improve access and efficiency and reduce the cost of delivering the service? So regardless of what model you choose, you're going to find certain common characteristics that are true from coordination to fully integrated care. It's also true in hybrid and virtual models. You're going to see these types of characteristics, and Karen's going to go into a little bit more detail about these specifically. But whole person care, it really is a continuum. And the nice piece is as your organization gains competencies in like how team-based care operates, sets up protocols for screening for social determinants and common behavioral health and physical disorders, you can also ramp up your integration as you get stronger in your current capabilities. And then your model starts to change as you go. Remember I said it was a journey? It takes time. Final piece in this first step of analysis is really the model, selecting the model itself. So you want to look at your state regulatory environment. There are just a range of possibilities here. Some states actually license a setting where a provider, a healthcare organization can deliver both behavioral health and physical health in a single outpatient setting. And these are three examples: Arizona, New York, and Pennsylvania, where they have those types of licensing arrangements. Other states are going to fall to accreditation and what accreditation standards allow. So places like Oregon, Colorado, I know New Jersey is in the process of setting up a setting that allows both behavioral health and physical health to be licensed in the same delivery site. So there's a lot of activity here. And then you're going to see community behavioral health, because certified community behavioral health clinics, because that really is the most common pathway that most behavioral health providers are choosing today. And so speaking of CCBHCs, that they're one of the many opportunities that are in the environment right now. And then more recently, Center for Medicaid and Medicare Services announced what they call an innovation in behavioral health model, which is very similar to CCBHC, but it does require that the care team at the behavioral health facility have physical care expertise. They both have a significant focus on social determinants of health, driving health equity outcomes, care coordination, and both of these models have opportunities for enhanced payments, which is one of the reasons that they're so attractive for many organizations that are moving into whole person care delivery. So I promised I'd show this. This is the Open Minds framework for integrated care service lines. And as you can see, there are many, many pathways to be able to deliver whole person care. And then finally, that last piece, which you don't want to forget, after you've done the market intel, you selected your population, you know what service, you know what location, how much will this cost, and how long will it take for you to achieve break even based on the financial investments that you have to make in order to forward your model. So more than just having an operations budget about what are the actual infrastructure costs, my one-time, my ongoing. More than that, you want to have that pro forma budget that allows you to test scenarios 2-3 years out into the future, so that you know at what point you will achieve break even, and then past that to earn positive revenues. And then finally, as a piece of the financial feasibility, what tools do I need to monitor my financial performance? So just sort of in summary, we've been through each of these steps. This is step one of moving into whole person care as a practice, as an integrated model. You're looking at your populations, you identified your services and programs, you know who your partners are, which can include staff that you hire yourself for delivering your whole person scope of service, and then identifying that best fit approach for delivering integrated care and a business model that makes it financially sustainable. So a high performing whole person care practice really starts with this type of a plan. And I'm going to turn it over to Karen now to talk with us about some of those core components of whole person care delivery. Karen, you want to take it away?
Thank you, Christy. I appreciate it. I appreciate everyone being with me today. I assume we're all here for some of the same reasons. We know that developing integrated care is something that we need to do. We are all here for the same mission. We want to see our consumers succeed and have great health outcomes. And yet this is a pretty complex process to make happen for our organizations. I think that one of the things that I really want to get across is that sometimes it's not a very linear process, even though it looks linear on our slides. So just a little vignette about my own background. I was with a specialty care organization in a semi-rural area in Maryland. We acted as a coordinating body with a local OMHC, and then later on formalized that relationship into a direct care organization relationship under a SAMHSA CCBHC grant. Then later that organization unfortunately lost their SAMHSA grant, so we continued the relationship, but they were in a process where they had no formal funding source for continuing that relationship. And we sought a CCBHC enabled partner to merge with instead. We merged with Cornerstone Montgomery, which was a certified CCBHC, but Maryland doesn't have a funding mechanism for CCBHCs yet, so that was also under a SAMHSA grant. I acted as the chief of programs within that organization, and where the setbacks came were that we had a co-located primary care clinic, and unfortunately, due to staffing issues that they had, they ended up moving out of our co-located clinic, and then we had to sort of retool and talk to SAMHSA and completely make a new plan. So I think one of the things I'd like to emphasize here is if you have setbacks, you may end up needing to make a new plan. So we'll talk a little bit more about the core components of whole person care. Next slide. There are 9 core competencies that we want to talk about within care delivery and care coordination services that are offered under a whole person care model. We want to look at our referral protocols and ensure that we are using a no wrong door approach. We want to offer right time, right care, right place services. And within that, we want clinical workflows that underlie that. We want those seamless, warm handoffs with information sharing and making that health information readily available to our partners, to our providers, so that we can do the gold standard, which is integrated treatment planning. As people come into our services and throughout their time with us, we want to make sure that we are screening for those health risks and social determinants of health. So here we're talking about the HEDIS measures, and many of those have actually changed in 2024. So we're thinking about ensuring all of those important screenings: breast cancer, colorectal cancer, adult immunization status, looking at our pregnant clients and making sure that we're screening for prenatal immunization status, pre and postnatal depression, that we're using validated instruments like the PHQ-9 and the GAD-7 to screen for depression and anxiety, and also monitor the progress of that depression and anxiety over the course of treatment. We also want to look in children's programming at screening for metabolic syndrome in children who are prescribed antipsychotics. We want to look at the follow-up care for children prescribed ADHD medication and screen for alcohol use disorder, and also offers smoking cessation. So some of those things, as well as within those social determinants of health, looking at issues of housing and lost my train of thought, sorry about that. Social determinants of health, looking at housing and economic conditions that underlie some of those social determinants. We want to look at health education and patient activation. So we want to encourage health equity and health literacy in the people that we serve. We want to make sure that we're looking at the chronic conditions in the people that we serve. This is where that population health data comes in. Who are we serving that is suffering from diabetes, high blood pressure, renal disease? How are we monitoring that? How are we ensuring those warm handoffs to specialists to help us take care of people? And in managing those health metrics, this is where some of the more modern technology is helping out. How are we remotely monitoring for medication adherence, blood pressure, blood sugar, and helping with that at-home care? Community referrals and social determinants of health providers. What are our relationships to ensure that when we're making those referrals, they're really happening? So whether we're able to provide those services under our own umbrella or through partnerships, those are things like adult daycare, vocational supports, psychiatric rehab, substance use supports. What do you offer, and what do your partners offer, and how are you going to address those gap areas? And then looking at complex care. We serve so many people with co-occurring disorders, very complex situations, medically, socially. So thinking about how we're managing those more complex consumers and responding to high-risk conditions. So what are our emergency and crisis protocols for medical, psychiatric, and substance use crises? Next slide, please. Within those core competencies, we have 9 care delivery and care coordination considerations that we need to think about. We want to emphasize that person-centered approach. The strengths, needs, abilities, and preferences of the individuals we serve because addressing those and in a strength-based manner is what underlies some of that patient satisfaction that we're going after. We want to think about the interdisciplinary teams. So we have multiple disciplines on a team. We're doing that shared treatment planning. And so when I think of these, I think of models like assertive community treatment or mobile crisis, where you have all of the disciplines represented and defined ways of working together and protocols for working together, best practices for working together. So really scoping out those protocols is very important. Workflow integrations. Are you getting care alerts from health information exchanges? How are you sharing information among yourself within your organization and your outside partners? Are you making sure that when a client is on a particular protocol, like a heart healthy nutrition plan, is that being carried through their services in their group home, or if they're getting referred to residential crisis, for example? And then our technology integrations. This goes way beyond an EHR. How do our other technology solutions integrate with that EHR? The telehealth solutions, transcribing, patient appointments, patient portals, and then how are those solutions being involved in our outcomes and our business intelligence integrations? We want those things to be in real time. We want them to be visible across the organization as part of that quality improvement effort. And then understanding that achieving our fantasy technology integration within our own organization is not enough. It has to also go across our partnerships. So assessing interoperability is really important. There are 4 aspects to interoperability that you need to be thinking about. There's the foundational interoperability, which is the ability to make information and data accessible across clinical, social, and community institutions. There's the structural interoperability, which is about data integrity across systems. The semantic interoperability, which is about the data definitions and codification, making sure that that's seamless across systems. And then, of course, the most important one, the one that we think about more often, which is that organizational interoperability. Do we have secure, seamless, and timely communications of data within and between organizations, and shared consent and security across those? Next slide. Oop, I'm sorry, not next slide. Keep it on this one. Telehealth solutions, we want to think about how we're offering that hybrid and remote care. And one of the important aspects of that, especially if we're maybe serving people across multiple states, we want to think about our triaging and risk management protocols when we're seeing people based on telehealth protocols. We want to consider our staff training and development. What gaps in staff training do we have? How are we segmenting that training and thinking about it based upon the different roles that people serve? How are we ensuring that those team-based models are working and that we're not duplicating services and not creating service silos? How's our performance management matching up to those team-based services? We also, within the team-based models and staff training and development, want to make sure that we're assessing evidence-based practices, cultural competency, motivational interviewing, peer services, trauma-informed services, just to name a few. We want to be sure that we're having a continuous feedback loop, collaborating with external stakeholders. So we're hearing from them, we're making improvements, we're letting the community know about the improvements that we're making, and that loop keeps continuing. Next slide, please. When we think about the 5 key elements of care coordination, we're kind of starting out with who is all involved in treatment. It's not just the consumer and the professional supports, it's also those natural supports. So coordination is necessary. Who's going to do what? Who's going to make sure that someone sees the specialist? Who's going to pick up the medication? How is medication being monitored? What happens in a time of crisis? What's the relapse prevention plan? Carrying out those activities in a coordinated way requires each participant to know their role and to avoid, again, those duplications in roles, redundancies, and to manage those required patient care activities. The goal here ultimately is the quadruple aim. We are looking at maximizing that patient experience, patient satisfaction, improving outcomes, improving health equity, and improving total cost of care. Next slide, please. So among those stakeholders, the patient, family, and community, there are 6 pillars when we're thinking about engaging them. We're thinking about education and advocacy resources and making sure that those are accessible and available in many formats. Depending upon your service area, you might be rural, you might be in the city. How are people getting their information? How is that information getting out about the services that you're providing? And especially the integrated services, making sure that people know that's available. Going back to the shared decision-making models, how are we ensuring that we're engaging the family, the community, and the client in the strengths, needs, abilities, and preferences, that person-centered treatment planning, and the consent that goes with that? In the in-home services, how are we ensuring quality and safety in those home-based services? And that's going back to some of what we talked about in terms of integrating some technology solutions. So this is a good place to think about medication adherence technology or some other remote monitoring options. Again, the social determinants of health. How are we engaging the community and our partners in addressing those issues? What are we involved in terms of housing initiatives and some of those other things that really underlie those social determinants of health? And then how are we engaging around rapid referral protocols? As we know, care deferred is care that never happens for the most part. So we really want to make sure that we've got that rapid access happening, just-in-time scheduling and some of those other protocols that are helpful. And then launching community health campaigns so that people know about what we're doing. Next slide, please. So within the education and advocacy resources, this is where I really want to emphasize the importance of provider training programs, both in our agencies and then in organizations and then outside with our partner agencies, doing some education development around the integrated care planning. And then advocacy initiatives, letting our legislators and the community know what's happening and what some of our needs are to align the regulations and funding with the things that our programs are doing. And I know here in my state, there's been a tremendous advocacy effort around educating legislators about CCBHCs, the payment models, why it's an important thing to invest in, and what the advantages will be for their constituencies. Next slide, please. Stakeholder engagement is a continuous circle of improvement. So kind of you're seeing the same themes here, the themes of holistic approach and patient-centered care, that we're keeping the eye on the person as an individual, but then also we're looking beyond that at the population that we're serving and the segments of that population. What are their needs? Health needs, psychiatric needs, social needs, substance abuse treatment needs, and really tailoring our services to those needs, coordinating and collaborating those services within our organizations and with our community partners, and optimizing resources so that we're avoiding those fragmented care and the silos. We are maximizing our resources by avoiding duplication, involving that community, helping to reduce stigma and reducing that resistance to change. And then using our advocacy efforts to have policy and regulatory alignment, and again, continuous improvement. So across all of those things, thinking about how we're going to improve next time. Next slide. We can't create those value-based payment arrangements without being able to define and measure value. We can look at value in a variety of ways, one of which is, of course, productivity. And I think we're all familiar with productivity metrics. We talk a lot about provider productivity, how quickly people get their notes done, and so on. But I think the thing that we often don't think about with reference to productivity is increasing productivity and efficiency is what opens up that access, that all-important access. And we really need to concentrate on opening access because we know the statistics around the number of people who have to wait for that initial assessment, and as a result of that, never have it. We want to look at those health outcomes. How are we measuring improvement? So that's back to those HEDIS measures. Did we screen for all of those needs? And then did we successfully refer and have that warm handoff? Are we reducing healthcare costs through reduced emergency room utilization, reduced hospitalization, fast follow-up after emergency utilization, hospital utilization? Are we seeing increases in engagement? Are people getting involved in their care? Are they using multiple modalities of care, self-care, individual and group treatment? Are no-shows decreasing? Are people taking advantage of day programs and social programs that are available? So all of these are ways that we can define and measure the value in our integrated care models. Next slide, please. Key performance indicators. These are some of the measurements that are typically used as indicators of our performance. And of course, they're not no good on their own. They need to be part of our quality improvement efforts. So typically, we're looking at improved efficiencies, workflows, referrals to treatment. What's the access to care? How soon does somebody get that first appointment? How quickly are they seen if they have been to the emergency room, been to the hospital? What about their health outcomes? How's their A1C? Have they had a nutritionist visit with their diabetes? Have they had better maintained housing? What are the actual outcomes of our care efforts? And then, are people satisfied with the care that they're receiving? Do they understand what care they're receiving? Then the healthcare costs. What's our unit cost? The real unit cost. And then what's the patient's total cost of care? So across all sectors of care, how much is it costing us on a per patient basis? And are we able to reduce that over time through improved services? And then, of course, our employees. How satisfied are our employees in working in our organizations? Because in my estimation and my experience, employees have greater job satisfaction when their clients are doing better. So as we see patient outcomes go up, we usually see job satisfaction going up as well. And some of those same themes that we talked about with the persons we're serving are important to our staff as well. We want to make sure that we're inclusive, that we're treating people with cultural competency, cultural humility, and that that's as much a part of being a staff member as it is being a client. Next slide, please. Of course, we need to take those organizational action steps. What are our next steps to achieving clinical integration? Do we need to develop more partnerships? Do we need to think through the services that we're offering and develop new service lines? What are the missing components to what we're doing? What support do we need to achieve integrated care? Is it that we know what to do and not how to do it? Is it that we're confused on where to spend our technology investments? They're so important and so expensive. What are the evidence-based practices that we have in place, and which ones do we not? How are we measuring the impact of that integration? Do we have solid metrics to present to the community or to payers about what we're achieving? And then what tools are we using to track those population health outcomes? Are they real time? Are they successful? Are we happy with our data integrity on those tools? And then also the tools that we talked about earlier with the integrations. So are we finding that our technology is easy to use? We have good adoption across the organization. All of those are considerations within the organizational action steps. Next slide. So Open Minds offers a readiness assessment, and it has 6 key domains that we're going to help you walk through and look at. We're going to help you look at your current model and think about what models there are to select from. We're going to look at the culture of integration within your organization. We know that integrated care is as much a reflection of the culture of your organization as anything. And we need to plan the financial funding to achieve these goals. We want to look at your care delivery and care coordination, all those things I just talked about, and how that integrates within your information systems and your population health systems. We want to look at your community engagement, how successful you are with that, and maybe where some of those efforts need to be ramped up. Next slide. Our readiness assessment is intended to help develop a roadmap for optimizing your integration strategy. That includes all aspects of that strategy: technology, staffing, reimbursement models, and identifying the steps and tools that you need to get there. Next slide. So again, back to the assessment. These are some of the steps in the assessment. Open Minds is able to provide a full service team to design, develop, and launch your model, and involve you in all 4 phases: that readiness assessment, implementation, technology assessment, financial, and that value-based care readiness assessment as well. Next slide. We have a 4-phase planning process. So getting clear on where you are and where you want to be, all the way through to your strategy implementation. Next slide. And in that planning, we want to help you identify technology strategy, performance optimization, staffing and practice development. Next slide. We want to support you with market outreach and sales. This is sometimes the trickiest part. As you develop that strategy and you're getting comfortable in the things that you're able to offer, how do you sell that to a payer? So we can help with that go-to-market strategy. Next slide, please. Every organization is individual, so we're able to help you individualize that strategy to where you are at this time and the things that you really need help with. So providing detailed financial scenarios, assessing your market and internal capabilities, and helping you develop your whole person plan of care. Next slide. We're able to begin services at any level or intensity of need that you may have. You can kind of think of this in 3 phases. That initial phase is maybe if you are at that coordinated level of care, or you're partially integrated, but you're not that far along the continuum yet. You're still needing a lot of assessment, planning strategies, education on whole person care models for your executive or management team, and market outreach. In phase 2, you're looking more at optimization strategies, how to improve from where you are. In phase 3, it's really about being able to take on risk-based contracts, capitation models, and health plan partnerships, and we can help with that too. Next slide. We can help you whether you are a provider organization, association, health plan, or accountable care organization, and tailor that strategy to what you need. Next slide. Ultimately, it's about creating a vision for integrated and sustainable whole person care services. Next. We're ready for questions and discussion.
Thank you, Karen. And if we want to take a moment to get Christy back here with us, get her camera back on. All right. Hi, Christy. Welcome back. We do actually have a few questions here. The first one from the audience says, how long does our assessment process take? And also, what is a rough timeline from start to go live?
Karen, do you want me to jump in first?
I'm going to let you jump in first on that one.
Yeah, but feel free to join. As Karen said, every organization is unique and individualized, so it really would be dependent on what kind of organization you have today, maybe even what state or part of the country that you're in. I would say the initial assessment, we would probably be looking at 30 days to 6 weeks to do those steps that I walked through at the beginning: market, model, customer, competitor, all those pieces, start to finish. So from assessment to implementation very much depends on you, your executive team. You probably have other priorities like serving people that are going to need to be factored into any kind of timeline. So that part, I don't know if I can give an answer to, because I think it would be so individualized.
I would agree with that. I think it's a very individual process, and some of it depends upon what your real capacities are to bring to bear on, moving that process ahead more quickly.
Yeah.
All right. Well, our second question is usually the first question, which is funding. So an organization would like to take this path. How would they secure funding?
I'll start. Karen and I have different experiences in this area, but I think when you start to look at how can I fund my startup, one of the obvious areas, of course, is grants. And there are a lot of opportunities there and probably one of the reasons so many organizations pursue the Certified Community Behavioral Health Center pathway is because SAMHSA puts out annual grants to help organizations with planning, and then another round of grants to help them with implementation. So you have SAMHSA grants. There's also through SAMHSA a whole initiative called Promoting Integration, which focuses on collaborative care for primary care practices to set up behavioral health, integrate behavioral health consultation. So there are grants for that. I also think you don't want to ignore just your local resources. So many of the examples that we've heard from Open Minds clients pursuing whole person care practices over the last years, many of them turn to their local hospitals and health systems who are often willing to fund a collaboration that results in, particularly for a health system, getting more rapid access to behavioral health for the people that are part of that health system, or reducing the numbers of your patients who show up in their emergency department. So they're often willing to fund either dollars or sometimes in-kind staffing support to your whole person care model. We've looked at, many states have incentive programs to support providers via Medicaid. Here in Arizona, we have something called targeted investments, which I think is now in its 7th year, and puts pretty significant performance incentives on the table for organizations that improve integration between behavioral health, IDD, and physical care. So those are just a couple of examples from my end of things. Karen, anything you would add?
For those of you that are in rural areas, very often rural areas benefit from health disparity related funding. So that might be something you could consider.
Yeah. And I think,
right.
from just one little add on to that, from my own personal experience, and again, remember, it was a very long journey for me, like 5+ years, multiple models. We set out, we didn't have any infrastructure funding. We set out with performance bonuses in our payer contract. And as we earned those bonuses by doing whole person care, by population health, by managing our more complex members, we earned performance bonuses that we reinvested in ourselves to be able to do the next step, the next stage on our integration journey.
All right, thank you, Christy and Karen. Next question for you. And an organization decides to take this path. Are there any natural populations or services that you would recommend as a good starting point?
Karen, you want to take that one?
Thinking about that. So, I started out in a behavioral health forward organization, and one of the kind of low-hanging fruit areas was we didn't have integrated substance use services, for example. So that was something that was an obvious addition to the services that we were offering. And in the case of once we were post-merger with the larger organization, again, they were able to pretty easily broker a co-location plan with a primary care. So sometimes that's a good in-kind kind of way to get started. And ultimately, even though that co-located primary care service had to leave for a little while, they did come back. So so things are proceeding well there. So I think, that's back to that 1 step forward, 2 steps back kind of relationship of some of these things.
And probably what I would add to that is, so low-hanging fruit always, look for your gaps in care. So all of your members are going to have, their behavioral health needs, their long-term service and support needs, as well as their physical care needs. And if you're only delivering a piece of that set of services, you need to get information about what are the gaps that they're experiencing, particularly healthcare gaps. So every, in Medicaid and in Medicare, every individual gets an annual wellness visit with their primary care provider, where there's screening, there's certain testing, there's management of your blood pressure, there's A1C testing for diabetes. If people are missing that, or even just immunizations for flu, is a big gap in care. So people who are missing those kind of vital healthcare services, if your organization can help coordinate reminders, maybe transportation to get them to the PCP appointment, campaigns that you can put together in your client population to remind people about their annual health visits, or other, if they're managing chronic conditions, you'll have some more opportunities there. But gaps are really a good place to get started. You just need the relationship and the data about what those gaps are in your client population.
Well, that does, in fact, bring us to the top of the hour. Christy, Karen, thank you very much for spending the time today to explain this to our viewers. I want to thank everybody who joined us, and I also want to remind everybody that the slides and the recording for this will be made available on the Open Minds website starting tomorrow, and that you can also join us next week, Thursday, June 6th at 1 p.m. Eastern for our next roundtable, The Right Metrics, Feedback-Informed Care and Patient-Centered Outcomes. To register for that event or for a full list of upcoming roundtables, you can visit us at the Executive Roundtables page under the Events tab at www.openminds.com. Karen, Christy, thank you again, and I hope everybody has a wonderful weekend.
Thank you.